Good morning everyone. Today I am going to take a class on infective endocarditis. What is infective endocarditis? Infective endocarditis is just a bacterial or a fungal infection of a valvular or a endocardial surface of a heart. What is generally means what? Just it is a infection, either bacterial infection of a endothelium of a heart. Usually it involves the valves. What are all the risk factors for the endocarditis? Usually what will happen? Usually what will happen in the endocardium is a protective layer which always inhibits the either attachment of a bacterium to a endothelium surface. But there are some risk factors which will damage this endothelium so that it will precipitates the attachment of a bacteria to the subendothelial layer. So any factors which will damage the endothelium, okay, increases the means which will damage the endocardium, which increases the risk factor. These are the risk factors for the infective endocarditis. So we'll go one by one. What are the risk factors for the infective endocarditis? Usually rheumatic arthritis. This is one of the major cause for your precipitating risk factors for your endocarditis. But rheumatic arthritis was the one of the major important predisposing factor for your infective endocarditis. This was actually true in a pre-antibiotic era. During that time it was the major. But now as we moving towards the more because there as such there is a rheumatic arthritis has been come down because of when we are using antibiotics for every in and out case of a upper respiratory tract infection. So the rheumatic arthritis has been reduced. Okay. Now actually any congenital disorders, heart disorders, especially VSD, TOF, okay, or any patent ductus arteriosus, okay, these are all the risk factors. Especially this risk factor, especially you have to suspect whenever the patient is coming with the pediatric age groups, right? Whenever the patient is pediatric, usually there will be congenital heart disease. Now especially suppose when a patient is getting a infective endocarditis at an adult, usually what we will suspect congenital disease, usually there will be bicuspid aortic valve, or sometimes what will happen in old age, there will be calcific or any degenerative valves, especially aortic valves, or there is any hypertrophic subaortic stenosis, or any MVPs, that is mitral prolapse. And these are all the very high risk factors for your infective endocarditis. In all these risk factors, usually what will happen, there will be a damage towards your endothelium. So you can see the VSD. VSD is what? There is a small defect in the ventricular septum. If there is a small defect in the ventricular septum, what will happen? There will be a gush during any systole. There will be a gush of blood flow from the left ventricle because it is in high pressure towards the right ventricle, because towards the right ventricle is always having a less pressure. So this gush of blood, whenever it is going to a small septum, this gush of it flow a turbulent flow. Okay, this will hit towards the right ventricle. It will damage this endothelium of the right ventricle. First thing is, okay, this endothelium damage, what will happen once this endothelium has been damaged? So naturally what will happen, once anything damages endothelium, once it exposes the subendothelial layer towards a blood, all your platelets starts getting accumulated at the subendothelial layer. Once platelet is aggregated, this always homeostasis mechanism will happen. It will aggravate further, it will aggravate all platelets, fibrin starts, then it forms a small clot. Once this clot will happen, okay, then any condition which will produce a bacteremia, any conditions which will produce a bacteremia, what are the any bacteria, suppose you just think that if any conditions which will get a bacteremia, suppose if the blood is having a bacteria, these clots, bacteria will pass through its clots and it form a protective layer of these platelets will be there, so it starts multiplying. That's the what is called as infective foci. So this is what is called as infective endocarditis. Means what? Once there is a damage to endothelium, then the subendothelial layer exposed to a blood, all the platelets are aggregating, then it's part of fibrin clot. If by mistake, if the patient is having any conditions which lead to a bacteremia, any condition which lead to a bacteremia, these bacteria will go inside to the clot and it starts multiplying there, because the immune mechanism can't penetrate the platelets, because it thinks that it is a natural, platelets is having always a natural, it doesn't have any immune system, so it forms a infective foci, then it starts multiplying. So now we have to go, what are all the causes for this bacteremia? Okay, any conditions which lead to a bacteremia will form everything this infective endocarditis. Usually what are the risk factors for this bacteremia? Once again is what? Any patient with a upper respiratory tract surgery or upper GIT tract, like any oral cavity, especially dental procedures, any gingival manipulations, okay, any gingival manipulations, upper respiratory tract surgeries, or any during any GI surgeries, especially during a lower GI surgeries, okay, or upper GI surgeries. These are all the conditions which leads to a bacteremia. Okay, if the patient is having underlying risk factors, what I told before, any valvular rheumatic valvular diseases or any congenital diseases, these patients undergoing any of these bacteremic leading predisposing factors will have a risk factors for this is infective endocarditis. Normally what will happen? Normally means what? Suppose normally whenever during brushing, anything like that, there will be minimal damage to gingival tissues. But if we have any predisposing factors like VSD, anything like that, usually the chance of infective endocarditis increases. But only thing is we have a good immune system, so we are not any predisposed to infection. So most of we also, whenever during brushing there will be a small damage to gingival tissue, usually bacteremia will happen, but it will go without any damage, because why? We have a good immune system and we are not predisposed towards the infective endocarditis, right? Usually what will happen? Regurgitant lesions are more susceptible than the stenotic lesions for infective endocarditis, right? Then how to classify the infective endocarditis? Before when I am in a UG, means what? When I am doing after 10 to 15 years back, we are dividing infective endocarditis into acute, subacute and a chronic. But now we are not classifying that one because it is not of any clinical significance. That's why we are now classifying into native wall endocarditis or any prosthetic wall endocarditis, right? Native wall endocarditis is what? Usually the colonization of a valve by bacteria or yeast that gain access to a bloodstream. Usually there is a native valve is, that is a normal valves, means we are not going a prosthetic valves, that's the meaning. Then transmit, that's what I told before, pathophysiology. Transient bacteremia is common during any dental procedures or upper respiratory, urological or a lower GI diagnostic procedures. I told you, bacteremia is common during dental, upper respiratory tract and a lower GI procedure. Means what? You can just see All these areas are where exactly more bacteremia, normal colonization will be there, dental, oral, or any during any lower GI surgeries, or any GI tract, I mean urinary tract, because these are the places where exactly most of the bacteria are present. Okay. Then otherwise, if we have any intravascular devices, means what? Intravascular device, if you just IV cannula, if the patient is having IV cannula is enough. This will have a portal of entry of a bacteria towards the bloodstream. Or if the patient is having any manipulations, means what? If the patient is having put any stents, arterial stents, that much is enough to become a bacteremia. Or now what? Now actually we are seeing more of cases of a patient with the intravascular heart disease, means what? If the patient is having intracardiac defibrillator, okay, or any pacemakers, if he kept directly on the heart, these are all the port of entry towards the bacteremia. And the patient is, this once you put a pacemakers or a defibrillator, this will damage the endothelium. So these are all the chances of getting infective endocarditis. These patients were very, very, very high. I told now, usually Staphylococcus endocarditis are most attributable to healthcare associated bacteremia. Means what? Suppose if we have put a catheter, for the catheter means intra-arterial catheters or defibrillator, intercardiac defibrillators, or any pacemakers, if they develop within infection less than 2 weeks to 2 months, then the chance of Staphylococcus is very, very, very high, because these are usually these are iatrogenic. Means what? Usually bacteria will be present in the skin. So you have to suspect a bacteria, especially Staphylococcus in these cases. Native wall endocarditis is usually caused by Staphylococcus aureus or Streptococcus viridans, Enterococcus or H groups. IV drug users, especially susceptible to Staphylococcus, accounts for over 60% of all endocarditis cases and 80 to 90% of cases in which tricuspid valve is infected. Enterococcus and Streptococcus compromise the balance in about equal proportions. Gram-negative aerobic bacilli, fungi, and unusual organisms may cause endocarditis injection drug abusers. Now I come into the prosthetic valve endocarditis. Usually prosthetic valve endocarditis early infections, means occurring in less than 2 months of the valve implantation, are usually commonly caused by Staphylococcus, especially both coagulase positive as well as coagulase negative, and a gram negative organisms and a fungi. Late prosthetic valve endocarditis means what? More than 2 months. It is usually caused by Streptococcus viridans. Although coagulase negative and coagulase positive still causes many cases. Coming to what are the classical clinical features of an infective endocarditis? What are symptoms and signs of your infective endocarditis? Actually, there are some criteria is there to diagnose infective endocarditis, that is called as Deuce criteria. But we are now that it has been criteria has been modified. So now what we are using is the modified Duke criteria to diagnose infective endocarditis. First I will go to the what are the clinical features, then I will go to what is modified Duke's criteria. What are the clinical features? First, what are the symptoms and signs present? Means what? Fever is present in most of the cases, but only thing is sometimes if the patient is having chronic infective endocarditis, then the patient don't present with symptoms of fever, they will present with something else. Means what? The patient is having already progressive cardiac failure, they may present with, or they present with just a peripheral signs of an infective endocarditis. I will tell you what are the peripheral symptoms. You think that just fever is present in most of the cases, especially acute. Chronic, it will be usually subtle. Then usually the symptoms and signs are caused by direct arterial valvular cardiac damage. Means what? Symptoms and signs depends upon the whether which valve it is involved. Infective which valve it is. Suppose if it is involved mitral valve, it is different. If it is involved aortic, it is different. If it is involved the tricuspid valve, it is different. So it depends upon the which valve it is involving. Second thing is the underlying cardiac condition of a patient. Suppose if the patient is already having a decompensated cardiac failure, then once infective endocarditis, the patient is going for decompensative cardiac damage. So usually these present, if the patient is having already a compensated cardiac failure, usually these patients will present it as a decompensated cardiac failure. They present it as. Otherwise, some patients they present it as either because as a result of a embolization, or it is a metastatic infection or immunological mediated phenomena. There are few characteristic peripheral lesions present in infective endocarditis, that is especially pette case, usually on the palate or usually conjunctival or usually beneath the fingernails you can see. There might be a subungual or a sphincter hemorrhages. Okay. Then there might be Janeway lesions. These are what? Painless erythematous lesion on the usually on the palps and the soles. One more thing is there, oscular nodes. What is this oscular nodes? These are the painful bilious raised lesion on the fingers, toes or on the feet. Sometimes we can see rod spots. Usually it is seen on the retina. You have to see in the ophthalmoscope. There will be exudative lesion in the retina. Okay. Otherwise, sometimes usually they present it as either as a stroke. It presents it as a cerebrovascular accident, or there may be any other embolic phenomena, especially if there is a peripheral arterial diseases. Okay, means what? If the emboli will go and block in the peripheral arteries, they present it as usually in the peripheral vascular, acute peripheral vascular disease. They present it as, or sometimes what will happen? They present it as just as a hematuria. If they go and block, produces a block in the glomeruli, they present it as hematuria and proteinuria because of this emboli or because of immunological medical glomerulonephritis. Okay, these are all the things. Then what are all the imaging we will do for infective endocarditis? Usually echo is a gold standard, but in this one transesophageal, first usually there are two things are there. One is transthoracic echo, another is the transesophageal echo. Usually transthoracic echo is good, but it is not gold standard because no, if there is a just angular abscesses, okay, if there are damaging the annulum of a what is it called, valves, transthoracic, it is difficult to detect. So transesophageal echo is almost 90% sensitive in detecting the vegetations, particularly useful for identifying a valve ring abscess, okay, as well as prosthetic valve endocarditis. So just remember, echocardiography is the diagnostic tool is there. In that one, transesophageal is more sensitive than the transthoracic. Then another method is what is we do is blood cultures. Blood culture is what? Usually blood culture will help to identify what organism is causing a infective endocarditis. This echo, everything will just indicate this signs and symptoms, everything will detect that patient is having a infective endocarditis, but it won't tell what organism is causing a infective endocarditis. So this blood culture is important to identify what organism is the causing the infective endocarditis. This blood culture, only thing is we won't take one blood culture for the infective endocarditis. What will we take? Usually 3 sets of blood culture at least 1 hour apart after starting a antibiotics, or 1 hour apart means before starting antibiotics you have to take the blood culture are recommended. Only thing is these 3 sets of blood culture we are taking now, we are taking from the 3 different sites, not from the same side. Suppose if you are taking a left upper limb once, means you have to take another one in the right upper limb once, another in the either in the femoral, like that you have to take. You have to take from the different sites. The problem with this blood culture is what? there are few entities are there in infective endocarditis. That is what is called as blood culture negative infective endocarditis. Means what? Means what? Organism is not growing a blood culture. Means what? Usually our routine blood culture, what will they? Usually the organism starts growing within 2 to 3 days. But sometimes few organisms are there which are not usually grown. That's why we were previously telling a blood culture negative endocarditis. Now has been sophistication has been improved. Now suppose if you are suspecting a patient with infective endocarditis, just call up the microbiologist and tell them, sir, I am suspecting infective endocarditis. Please increase, either use specific medias if you are suspecting some specific organisms, or use some artificial medias, or tell him to put a media for a prolonged incubation period. Means what? Few organisms are there which is having a prolonged incubation period. I will tell one by one. Usually some organisms are there which are not usually grown on artificial medias. So if you are using some natural medias, okay, most of the organisms are grown, but there are few organisms are there, especially Prophylaxis vipelli are the organisms which is causing Q fever and the psittacosis. These are all usually not grown in the artificial medium. Okay. Then some organisms are there that will require a special media, not a routine media, to grow, especially Legionella, Bartonella, Homeotropia species. Okay. These are all require some special medias. And few organisms are which are very slow growing. If you just wait for 7 days and if you remove the blood culture media, usually we will miss these organisms, especially brucellosis, anaerobes, and these achac groups is there. What is this achac? Haemophilus, influenza, actinomycosis, corynebacterium, Echinella, and Kingill organisms. Okay, these are regarding your blood culture. Then coming towards I told what is criteria to detect a infective endocarditis. In this one we are divided into what is the criteria you are using to identify infective endocarditis is a modified Duke's criteria. In that one you are divided into major criteria and the minor criteria. What is there in major criteria? These major criteria include 2 positive blood cultures for a microorganisms that typically causes infective endocarditis or a persistent bacteremia. Not one positive blood culture, it is not significant. 2 positive blood cultures for a same microorganism which are typically causes the infective endocarditis. Second thing is, if there is a evidence of endocardial involvement or a documented by echocardiography, definite vegetation should be there, or there might be myocardial abscess or a new partial dehiscence of a prosthetic valve. Third major criteria is the development of a new regurgitant murmur. Means what? That's what I told. New murmur or a change in murmur. Means what? I told the risk factors for the infective endocarditis. There will be VSD will be there. Okay. There might be patent ductus. Usually this will also produce a murmur, but or even rheumatic arthritis is there, MS is there, MS is there, MS arthritis. This usually they produces a murmur, but routine if you keep on auscultating, if there is a change in murmur, suppose if you are seeing yesterday, if a patient is having a fever, you see yesterday it doesn't, but you are seeing an immediate next day or day after tomorrow, you think that the murmur has been changed. Means what? Either it may be changed from the mild to severe within 1 day, or there may be a development of some new murmur. Suppose if there is today is MS, tomorrow is developing MR murmur, you have to think of infective endocarditis. That's the meaning. Then what is the minor criteria for this infective endocarditis? Presence of a predisposing conditions. That's what I told. All this rheumatic arthritis is there, or there might be any bicuspid aortic wall, otherwise congenital arthritis like VSD, patent ductus arteriosus, or any TOF. These are all the predisposing factors. Patient is having a fever of more than 38 degrees centigrade, or any vascular phenomena. That's what I told you. What are the vascular phenomena? Either what is that called? Any cutaneous hemorrhages, petechiae we can see, or there may be new development of aneurysms because of a vasovascular damages, and then patient artery go for aneurysms, or maybe systemic emboli. Means what? Any patient is develop a stroke, or they develop MI, or they develop a pulmonary infarctions. That means what? They develop a pulmonary embolus. Our third criteria, major criteria, is developing a immunological phenomena such as glomerulonephritis, Osler's nodes, Roth spots, or a rheumatoid factor. In this one, minor criteria is there: positive blood culture not meeting a major criteria, or a serological evidence of a active infection. Means what? If there is only one blood culture is positive, the meaning is if there is one blood culture is positive, that is the meaning. Then, when we will tell a definitive diagnosis of infective endocarditis, if two major criteria is present, or one major criteria and three minor criteria is present, or five major criteria are fulfilled, then we tell it is a definitive diagnosis of infective endocarditis. Means its accuracy is about 80%. We will tell possible infective endocarditis is made if there is only one major criteria and one minor criteria, or three minor criteria are met. If suppose only fewer criteria are present, if we can able to make some roughly good alternative diagnosis, then the patient is still febrile, has not resolved within 4 days, endocarditis is very unlikely. What are the complications of this endocarditis? Usually the course of infective endocarditis is determined by a degree of a damage to aort, by site of infection, right sided versus left sided, aortic versus mitral, by the presence of a metastatic foci of infection, by a occurrence of a embolization, and by immunologically mediated some process. How to prevent this infective endocarditis? The AHA, American Heart Association, recommended antibiotic prophylaxis for infective endocarditis in a relatively small group of patients with predisposing either congenital or a valvular anomalies, undergoing selective dental procedures or operations involving a respiratory tract, or operations of a infected skin structure, or a musculoskeletal tissue. So these are all the procedures where we have to prophylaxis are recommended. So what are these procedures? All dental procedures that involve a manipulation of a gingival tissue, or a periapical region of a teeth, or a perforation of a oral mucosa, or any respiratory tract procedures, especially only respiratory tract procedures that involve incision of a respiratory mucosa, we have to give prophylaxis, or procedures of a infected skin structure, or a musculoskeletal tissue, we have to give a infective endocarditis prophylaxis. Prophylaxis are not recommended for dental procedures, routine anesthetic injections, though non-infected tissues, taking dental radiographs, or placement of a removal of a prosthodontics or orthodontic appliances, or adjustment of a orthodontic appliances, or placement of a orthodontic brackets, or shedding of a deciduous tooth, and a bleeding from a trauma of the lips or a oral mucosa doesn't require a prophylaxis. Or GI tract procedures and genital tract procedures usually not require prophylaxis, they are telling. So what prophylaxis we will do? We will give. Usually oral, if you are giving, usually we will select a clindamycin, cephalexin, azithromycin, or clarithromycin we will select. If you want to giving parenteral, if the patient is having a penicillin allergy, we will usually will give clindamycin or a cefazolin. Then coming to the what is the treatment. Treatment, always I told, depends always on the what organism it is causing a treatment. But once we suspect, we can't wait for until the blood culture reports come. So we will start empirically. Once the blood culture reports came, based upon the sensitivity and everything, we will select. Until that one, we will start treating empirically. What we start empirically is the vancomycin will start 1 gram every 12 hours intravenously plus ceftriaxone 2 gram every 24 hours provides usually give a good coverage until the blood culture reports are awaited. Then we will go specific organism. If you suspect, if you identify Streptococcus viridans, if it is penicillin susceptible, Streptococcus viridans endocarditis will give penicillin G 80 million units we have to give intravenously, either continuously or 4 to 6 equal divided doses, or we can still give ceftriaxone 2 gram intravenously OD for 4 weeks is recommended. Duration of therapy can be stopped out to 2 weeks if gentamicin is used with penicillin or a ceftriaxone. Then coming to a enterococcus. For endocarditis, usually we will select a penicillin or ampicillin alone is inadequate. The combination of penicillin and ampicillin with gentamicin has been treated for a choice, but several clinical studies of combination of ampicillin plus ceftriaxone has demonstrated a clinical outcomes equivalent to a combination of ampicillin plus gentamicin. Ampicillin 2 grams intravenously every 4 hours. Penicillin G 18 to 30 million units intravenously continuously in 6 equally divided doses plus gentamicin 1 mg per kg intravenously every 8 hours. The second recommended regime is usually ampicillin 2 gram intravenously every 4 hours plus ceftriaxone 2 gram intravenously every 12 hours we can give. Usually recommended duration of treatment is 4 to 6 weeks. Coming to Staphylococcus. If it is methicillin susceptible Staphylococcus aureus, either we will give nafcillin or oxacillin 12 grams intravenously daily given continuously or in 4 to 6 divided doses, or cefazolin 6 gram intravenously daily given continuously or in a 3 divided doses for 6 weeks in is the preferred therapy. If it is methicillin resistant Staphylococcus who are unable to tolerate a beta-lactam therapy, vancomycin we have to give 30 mg per kg per day intravenously divided in 2 to 3 doses to achieve a goal through a level of 15 to 20 micrograms per kg, or daptomycin intravenously at a greater than or equal to 8 mg per kg per day we have to give. Then for Achak groups, what is this Achak? I told it is Haemophilus, Echinella, Kengella groups. Usually these slow growing and fastidious gram negative Coccobacillus, these are the normal oral flora. Usually less than 5% of the cases endocarditis only will be positive for these Achak groups. Usually they these Achak groups are there, no? Usually they may produce beta lactamases and thus the treatment of choice is ceftriaxone or any other third generation cephalosporin is very good. 2 gram intravenously once daily for 4 weeks you can give. If there is a prosthetic or endocarditis, treated for 6 weeks. In penicillin allergic patient, experience is very limited, but fluoroquinolones we can try. Still so much advancement, there is still called as culture negative endocarditis. Means what? There will be usually all echocardiography, everything, all the peripherals means suggest that it is an infective endocarditis, but blood culture is still negative for this endocarditis specific to the organisms. Why this is happen? Failure to culture microorganisms for patients with suspected endocarditis may be due to infection from organisms not recovered in routine microbiological testing, or previous administration of antibiotic agents before blood cultures were obtained. These cases must be managed with the assistance of a infectious disease specialist. Otherwise, pathogens that are not able to be cultured by commonly used techniques include Bartonella species, Chlamydia species, Brucella, and Troponema vipali. You have to use some special medias, and you have to use a prolonged culture you have to keep. Otherwise, you have to establish a serological testing. If you can't able to grow a blood culture, you have to do serological testing should be performed for epidemiological risk factors for these infections. Treatment should be directed at the likely pathogens, avoiding serological reports, but that's what empirically we have to treat. Then, is there any role for surgery in infective endocarditis? Definitely, there are some role is there. There are many cases which can be managed by medically, but few patients, especially acute heart failure unresponsive to medical therapy, is an indication for valve replacement. You have to remove the whole valve if the patient is having acute heart failure which is not improving with the routine medical therapy. Then surgery is nearly always required for a cure, especially in a fungal endocarditis, and more often in a highly resistant bacteria are there. Okay. Then only this will come. We are coming to the end of the topic. The question is just write it as a main question. Describe definition of endocarditis. Okay. Then what are the etiologies, clinical features, and the management of the same. Just write in an assignment form and submit it within 3 days. Thank you.